Hello everyone, I'm Sandra Avadir, a third-year medical student at Ross University School of Medicine. Today, I want to present to you a clinical vignette on a case that we recently encountered. This is a case of a 64-year-old woman that presented to our emergency room for a non-productive cough and progressive shortness of breath for 3 months. The shortness of breath was initially on exertion, and during the last month it worsened to occur at rest and was unrelated to position. She was diagnosed with metastatic ovarian cancer earlier in the year and underwent 6 months of treatment with carboplatin, paclitaxel, and bevacizumab. Before presenting, her regimen was switched to paclitaxel and bevacizumab only. On admission, she was standing at 85% on room air, and her labs were significant for elevated pro-BNP and troponin. An echo revealed severely dilated right ventricle and right atrium. Right heart catheterization showed elevated right ventricular systolic pressure, pulmonary arterial pressure, and pulmonary vascular resistance. Her pulmonary capillary wedge pressure, cardiac output, and cardiac index were reduced, as seen in Table 1. Based on these findings, she was admitted to the ICU for severe pulmonary arterial hypertension and was started on IV and inhaled epiprostenol and sildenafil. However, she developed severe hypoxia and required mechanical intubation and eventually needed ECMO. Her course was further complicated by a PEA arrest and multiple brain infarcts seen on CT scan. Due to the severity of her case, her family opted for hospice and she expired shortly after. Bevacizumab is a recombinant humanized monoclonal antibody that has been used in multiple cancers to inhibit vascular endothelial growth factor A and prevent angiogenesis. It was first approved for colorectal cancer and has since been used in the treatment of ovarian, lung, renal, and neuronal tumors. Some common adverse effects of this therapy is hypertension, bleeding, arterial thromboembolisms, and even GI perforation. But the development of pulmonary arterial hypertension is extremely rare, and there have been very few cases reported. There isn't any guidelines currently for screening after the use of bevacizumab except for regular labs and urinalysis with protein levels. Pulmonary hypertension can be classified into 5 groups based on the World Health Organization. Group 1 is the primary pulmonary arterial hypertension, which is mostly idiopathic but also has been associated with connective tissue diseases and drugs like amphetamines and chemotherapeutic agents. Due to the very limited bevacizumab-induced pulmonary arterial hypertension cases, we lack guidelines for radiographic screening. Furthermore, it's not even clear if the screening with echo and right heart catheterization is beneficial, as there hasn't been any treatment modality, including ECMO, that has been successful in improving the mortality in these patients. In summary, further data is required for developing screening and treatment guidance in bevacizumab-associated pulmonary arterial hypertension. Thank you.